trauma is a disease and should be managed as such. It's a predictable disease, it's preventable. It's a leading cause of death. And I'm not sure about the statistics in Kenya. Try to look for this, but there's no easy way of getting these statistics. I'm not sure, we don't have a trauma registry here. And I think as we go slowly by slowly, we are going to get that on. I think maybe Dr. Washira will clarify on this later. There are 4 million deaths per year worldwide from trauma, so it's really, really significant. I think it's even now, trauma is more than COVID, but we're focusing on COVID, which is acute. And there are about 312 million people who are injured from trauma in 2020 worldwide. So as you can see, it's a significant disease. We have to be on when managing trauma because, as I said, it's preventable and it's predictable. There's a trimodal distribution of mortality, and as you can see there's a pre-hospital where people will die with major head injury, rapid exsanguination, aortic injuries, cardiac injuries, and all that. But where we want to get these patients is early hospital. When they come into hospital. So that means when they come to our emergency departments, that's where we want to get them. That's where we can make a difference. Not in the pre-hospital, not at the site, but after they are picked up by paramedics. So this is someone who survived the initial trauma. So they come to hospital. This is where we should apply our knowledge to try and save these people. So the ones that will arrive there have head injuries, chest injuries, abdominal trauma, minor injuries, and we should try and save them here. That's where we'll save their lives. That's where we'll make a difference in the amount of time they are going to be admitted. And of course, some of them will go to hospital, and the very severely injured will go to ICU, which sometimes going to ICU is an end result of prolonged hypoperfusion and other injuries that we have not picked and corrected in the early hospital. And I should have put that in red is the emergency department, really, A&Es. That's where we should get them. In advanced countries, there are trauma systems. They have enough resources to have trauma levels, trauma hospital levels, and where they are designated level 1, level 2, level 3, level 4 trauma, even level 5 trauma. And as I said before, I hope that one day we shall get here where we shall have trauma facilities in this country where we shall be able to manage trauma as we are supposed to. So our local systems here, I think we have tried our best. We have some pre-hospital care. Paramedics do a good job in picking up these injured people and bringing them to us. In the hospitals, I think we are doing as best as we can, but we should do better in our emergency departments, and maybe we should look at having trauma calls, trauma teams, or trauma units, where we shall get a call, a pre-warning from paramedics, and we shall put our teams together. We shall alert the emergency department. We shall have a resuscitation team at hand. We shall have a surgeon who will attend, a general surgeon. I think orthopedic surgeons come a bit later down the line. We shall have the lab waiting with blood, be it for massive transfusion. They shall be ready. We shall have the theater cleared, depending on the number of casualties arriving. They shall be clear. We shall have an anesthetist on hand, and all that. And one day, I think we shall get there. And then, of course, we have to focus on ongoing education. Is our ATLS training in this country, is it unified? There's one body that is in charge of doing trauma training? What is that? What is our recertification like? Is it that we only do one ATLS course and that's it, and now you do not, to get a recertification is basically non-existent? So these are some of the things apart from the clinical aspects, the raw clinical aspects of trauma that we should look at. And slowly and surely we are getting there with things like with organizations like Emergency Medicine Care Foundation, which is doing a very good job. and the guys who train at TLS, led by Dr. Ojuka, from the surgeons from Kenyatta. We're doing a good job, and we are getting there. So trauma is really a big thing. So I think in our emergency departments, we should, if we get a trauma call, and some of us are lucky to be notified before the trauma arrives. And some of them, they just get there, they just bang on the ambulances on the door with a patient who is trying to die, and they throw them to you, and you just have to sort out this patient. So I think if a patient comes in, just a quick handover from the paramedics, and there's a small pneumonia. Missed, what was the mechanism of injury? Did you find any injuries, even if they've been brought by a good Samaritan or a bystander? How was the patient like? Was the patient alive? What symptoms did they have? Was he talking when you picked him up? Was he breathing spontaneously? Was there any bleeding? And if it's paramedics, what treatment created? So just a very quick history, and I mean not a history like, oh, when was the patient born and what allergies and all that. Of course, allergies you can ask, but just a very quick focused history so that we get on to the job of resuscitation and managing this trauma. Trauma, in order to successfully manage trauma in a good way, in a good fashion, we should always have a systematic approach to managing trauma. Systematic approach, and you do it all the time, and you shall get better at it, and it shall avoid and it shall prevent you from missing a lot of things. So we do a primary survey, secondary survey. The primary survey, we seek and treat injuries, and I think the primary survey is not only just looking and identifying it. I think you look and correct. So put there seek and treat. So in the airway, remember in trauma, airway always goes with cervical spine protection, because you're not going to save this guy's airway or this patient's airway and then you give him a high spinal injury. So airway with cervical spine protection, breathing, circulation, disability, and exposure. So of course in the airway you are trying to look for things that will obstruct his airway. Trauma to the C-spine can also impede your airway. Remember that the diaphragmatic nerve, cervical spine 3, 4, 5 keeps the diaphragm alive. So a C-spine injury, an obvious C-spine injury, then is going to affect the airway. So you seek and correct these things so the patient comes in, look at his airway and correct, apply supplemental oxygen, clear the airway. The patient is vomiting, suction him or her. There is a knock on the mouth, clear the airway, apply oxygen. All that time maintaining inline C-spine protection. You can put a collar, and remember there's new emerging evidence that collars are not really very essential. They are essential. They remind us that the patient has a potential C-spine injury. So you can either use a rigid collar, or you can put sandbags. You can do sandbags and tape, and just to immobilize the C-spine. Then you go to breathing and ventilation. So you put the patient on a monitor. What is the patient SATs like? You put supplemental oxygen, but that's not going to affect maybe his ventilation. He has maybe a flail chest. There's a surgical emphysema on the chest. The chest is not moving. So you correct that, and we are going to come to that, injuries that will affect breathing. Go to circulation. There's acute hemorrhage control. If there's a limb hosing, there's a vein hosing, put pressure on it. And continue your primary survey. Go to disability, GCS, eyes open. Expose the patient with environmental control. Make sure the patient is warm. If it's a cold day, dry him up. If he's wet, we forget to do it, or we don't do it very well. And I'm just going to play a video of log roll.
It takes 4 people to properly log roll a patient. This procedure keeps the patient's entire body in neutral alignment and minimizes any movement of the spine. It is helpful to cross hands at the patient's hip so that the team members at the patient's side will move together when rolling the patient. When signaled, roll the patient and remove the backboard. Now is a good time to evaluate the patient's back. When signaled by the person at the head, roll the patient to the supine position.
Then after that, just let's go to a secondary survey where we can get further history, an ample history, which that's a mnemonic for allergies, medications the patient has used. The patient might be injured and is bleeding and is on anticoagulants. So let's get a history of medications used. The patient might be obtunded, altered GCS, taken some benzodiazepines or something like that. Get a history of past illnesses, if they have a history of ischemic heart disease, stuff like that, and relatively hypovolemic, at risk of myocardial events. Get a history of the last meal he ate, and is fasted or not. They might get for control or for further management, and just a bit more detailed history of the events that happened. Then do a head-to-toe evaluation, a complete physical examination, which head-to-toe, and documenting your findings. And of course, remember, if you have not once you find if you find an abnormality, find a problem, and treat all the time. In the head, you look for scalp laceration, fractures. Look at the patient's eyes, maxillofacial, any maxillofacial injuries and oral injuries. In the neck, of course, and this is not all, this is just some highlights. On the neck, you look at the patient's carotids, and the chest you examine on the back of the patient. And in the abdomen and pelvis, look for intra-abdominal bleeding. We are going to touch briefly on it later. And just look at a musculoskeletal assessment. Look for long bone fractures, any obvious wounds that will need attention, and of course the CNS, pupils, etc., and document all those findings. So this is just a general highlight on how to examine this primary and secondary survey. This is not exhaustive, and we have all these resources online. You can just go to our website, Emergency Medicine Care Foundation, and we've detailed a lot of stuff there. So let me just go back to airway and breathing. I mean, this is something that kills a lot of people, and a trauma airway can be challenging and difficult even for the best top anesthetists. This picture here, the one I've put up, is a patient I had, a trauma patient. So he tied a rope and noose around his neck, tied it to a post, and got into his car, a manual car, and engaged gear 1 and drove off. He wanted to kill. Brought to us by ambulance about 30 kilometers away, and his neck was flexed because I think he had a partial anterior laceration of laceration of his trachea. He had protected his trachea halfway. So he came in, and when we examining him, one of the doctors just touched his head up, and immediately there was a lot of surgical emphysema on the neck, and the neck was bloated. And then we tried intubation from the head, but we are lucky, we had been told about the injury, so we had prepared. So trauma airway, always be ready for a surgical airway. So you will try and intubate these patients. You'll try and secure the airways, and if you cannot, you have to be ready to intervene surgically. So luckily, we are ready to intervene surgically, and we managed to get a surgical airway in situ. So this is just a trauma airway that not many of them, this is a minimal of them. Majority of them will be clear them and suction them, apply supplemental oxygen, and they'll be good to go. But always beware. Remember, the neck is part of the airway. There's a neck injury, there might be the air be affected. So always be ready for that. So you can use airway adjuncts, oropharyngeal airways, nasopharyngeal airways to oxygenate these patients. And remember, when you're intubating these patients, you have to do an inline stabilization or put a C-collar, which might impede your intubation attempts. So you can take out the C-collar and get someone, an assistant, to manually hold your neck, the patient's neck inline, and then intubate them, of course avoid hyperflexion. And all this makes the airway very difficult. It just turns it into a difficult airway. I'm just going to the next slide. So another thing, remember that not all patients will need to be intubated, and we should not get fixated at intubating patients. We can bag them and just bag them effectively. And I'm just going to play a video of effective bagging of patients.
First, select a mask that fits the patient's face. Connect the oxygen tubing to the bag mask device and adjust the flow of oxygen to 15 liters per minute. Make sure that the patient's airway is open and secured. The first person then applies the mask to the patient's face, performing a jaw thrust maneuver and ensuring a tight seal with both hands. The second person applies ventilation by squeezing the bag with both hands. The adequacy of ventilation is assessed by observing the patient's chest movement.
When you are assessing the airway, an altered conscious state, an altered mental state is also concerning, because these patients will lose their airway reflexes. Facial trauma and burns, as I said, will also affect the airway, so inhalation or injuries, which will lead to airway edema. And actually, some of these patients who come with massive burns with inhalation or injuries, and there's even a hint of any airway injury, are electively intubated to avoid a difficult airway. And so maybe they have edema, they have soot in their airway, they have singed their nasal hairs, and there's any significant burns, they are electively intubated to prevent edema, because edema forms very fast. So patients with neck injuries, I've said, laryngeal fractures are a concern, and they need airway protection early. This is airway and breathing injuries. So remember, after you've intubated these patients, you have to ventilate them. And in chest trauma, if they have blunt penetrating injuries, ventilation or breathing will be a problem, and you have to intervene early. So beware in chest trauma, beware of elderly patients or patients with pre-existing pulmonary dysfunction. A patient with COPD with a few rib fractures will be more at risk than a patient with a young, healthy patient. Pediatric patients also can get injured with no rib fractures, and they can have severe lung contusions, and you've X-rayed them, and they're still maybe CO2 retaining, or they're just dropping their stats, and they could have chest trauma that we cannot pick from plain X-ray. So we have to consider that. Intracranial injuries also, as I've said earlier, affects airway and breathing, and cervical spine injuries. Remember, the mnemonic, the adage C3, 4, and 5 keeps the diaphragm alive. So always beware of that. I'll just touch on a few at tension pneumothorax. And one thing I have to say is that tension pneumothorax, you do not need an X-ray to diagnose a tension pneumothorax. Tension pneumothorax is a life-threatening injury that can kill in minutes. So we have to be aware of that, especially patients who come with obvious blunt trauma to the chest, or even if they've formed a one-way valve. And clinical signs point to a tension pneumothorax, or they have arrested in the emergency department. There's some departments where a patient traumatic arrest cannot be declared dead unless they have had bilateral finger thoracostomies. So you have to rule out a tension pneumothorax. So one-way valve air leak from the lung or chest wall, the air is forced to the pleural space with no escape. There is displacement of the mediastinum, decreased venous return, the opposite lung compresses, and they just go into obstructive shock. These are true surgical emergencies, a life threat, and patients can either present with respiratory distress, they have subcutaneous emphysema, absent or unilateral breath sounds, and a hyperresonance with a tracheal shift. This is just an X-ray showing a tension pneumothorax, and it never needs to get here. You never need to get to x-ray, but if you see it's a radiological tension is a nearly a late sign. Maybe I think in this x-ray, I got it from the internet. Tension pneumothorax needs to be drained urgently. The treatment of a tension pneumothorax is not a chest tube insertion. I'm going to repeat that again. Treatment of a tension pneumothorax is not a chest tube insertion. It is a needle or finger thoracostomy. And this, once a patient arrests, if a patient has come with a tension pneumo and they arrest, I think you'll never get them back. I'm just going to play a video on needle thoracostomy.
Needle thoracentesis is the initial treatment of suspected tension pneumothorax. The site used for a needle thoracentesis is the second intercostal space in the mid-clavicular line on the side of the suspected tension pneumothorax. An over-the-needle catheter that is at least 2 inches or 5 centimeters in length is inserted into the chest over the top of the third rib into the second intercostal space, puncturing the skin, intercostal muscles, and parietal pleura. A sudden escape of air from the end of the needle both confirms and relieves the tension pneumothorax. The needle is then removed, leaving the plastic catheter in place. If equipment is available, the needle thoracentesis should be followed by prompt placement of a chest tube in the 5th intercostal space of the affected hemothorax, as described elsewhere.
So when you do a needle thoracocentesis for tension pneumothorax, it should be followed up by a chest drain, a formal chest drain. And there are spaces. I'm going to play a video of a chest drain insertion. In other places, actually in advanced trauma centers, they don't do needle thoracocentesis. They do finger thoracostomies. You get a scalpel, slash that skin, put your finger inside, relieve the tension, and keep your finger there until someone else can put a chest drain. And that's done very, very fast. As I said, if a patient is arrested, you have to do bilateral. That has to be ruled out. You're not going to do an X-ray or whatever. It's a traumatic arrest resuscitation. So you do a bilateral finger thoracostomy to get that out of the way. So the next video is just going to be of insertion of a chest drain and safe spaces to insert the chest drain.
The site most often used for chest tube placement is the 5th intercostal space just anterior to the mid-axillary line on the affected side. External landmarks for this site include the nipple level in males, the inframammary crease in females, or the width of the operator's hand placed in the patient's axilla. If the patient's condition allows, take time to position the patient's arm above the head, don a sterile gown and gloves, surgically prepare and drape the patient's chest, and locally anesthetize the skin and periosteum at the insertion site. Make a 2 to 3 centimeter transverse or horizontal incision with a scalpel at the insertion site and bluntly dissect through the subcutaneous tissues just over top of the rib. Using the tip of a large clamp, puncture the parietal pleura above the rib and enter the chest cavity. While withdrawing the clamp, spread the tips in the intercostal and chest wall muscles to create a hole large enough to admit the operator's gloved finger. A gloved finger is placed into the chest cavity to assure that the chest has been entered, and that any adhesions of lung tissue to the chest wall are swept free to allow easy insertion of the chest tube. An appropriately sized chest tube is advanced into the pleural cavity through the previously created tract and directed posteriorly along the inside of the chest wall and towards the apex of the lung until all of the drainage holes on the tube are inside the chest. Placing another clamp placed on the opposite end of the tube will prevent blood in the chest from draining onto the bed or floor. Fogging of the chest tube with expiration, air movement, or drainage of fluid from the chest suggest successful placement of the tube in the pleural space. Once the tube has been placed in the chest, the remaining end should be connected to an underwater seal collection device and hooked to suction. The chest tube is then securely sutured in place, covered with an occlusive dressing, taped to the chest wall. A chest radiograph should be obtained to verify tube position, and the patient should be further monitored with pulse oximetry or arterial blood gases as indicated.
Yeah, I'm just going to say something about chest drain insertions and trocars. Most chest kits, chest drain tubes here come with a trocar. In my opinion, the trocar is just supposed to keep the chest drain from kinking. Trocars should not be used on insertion of chest drains. Trocars have been used before with devastating and very bad effects. So you find trocars in the heart, you find them in the liver, you find them in the mediastinum, you find them in lung tissue itself. So the first thing that we teach when you open a chest tube kit, take the trocar away and throw it away as far as you can. Avoid using trocars during insertion of chest drains, and the dissection through the chest wall ideally should be done bluntly or through, as you've seen through the video. So do not use trocars for chest drain insertions. So open pneumothorax, something you can find in trauma as well, in airway breathing. That's also known as a sucking chest wound, and it just equilibrates between thoracic and atmospheric pressure. Patients can present with pain, difficulty in breathing, decreased breath sounds, noisy air movements through the chest wall, and this should be attended to as a matter of urgency. So close the defect with sterile dressing, and as a temporizing measure, you can put an occlusive dressing and tape it securely on 3 sides, not on 4 sides, so that you want to create a flutter valve effect so that air can come out and not stay in. Taping all 4 edges may lead to air trapping and a resulting attention pneumothorax. And then remember to put the chest drain away from the wound. And of course, with open pneumothorax, surgical closure is often unavoidable. So that's how you should you can dress open pneumothorax. As you can see from the diagram there is this area, this edge that is left free, so that you do not, so just a flutter valve effect, so that you do not create a tension. Massive hemothorax, that's breathing and circulation as well. This is when you have more than 1,500 mils of blood coming out of the chest wall. Your aim here is to restore blood volume and decompress the chest cavity. Patients should have a wide bore IV access, and you can these patients may need transfusion because they can lose a lot into the chest cavity. And you can consider auto transfusion in these patients if you have the facilities to do that. And these patients will need an urgent thoracotomy. And the indications for urgent thoracotomy include some 2 indications there: more than 1,500 mils of blood drained, or more than 200 mils per hour over a 2 to 4 hour period. So you put in your chest drain, and this patient keeps on hosing more than 200 mils per hour. They might need the chest needs to be opened for exploration and management. And as usual, always consider the hemodynamic status of this patient. So airway, breathing, circulation should be considered. Come to cardiac tamponade. These are compression of the heart by accumulation of pericardial fluid and in trauma blood. You remember the Beck's triad of muffled heart sounds, hypotension, distended neck veins. They can have Kussmaul's a Kussmaul sign, which is paradoxical rise in JVP during inspiration, or failure of appropriate fall of JVP during expiration. And these patients, if they arrest or new, the common dysrhythmia there, arrest rhythm will be a PEA. Of course, managed according to standard ACLS trauma resuscitation guidelines, but definitive management is a pericardiosynthesis, which is temporizing, then a thoracotomy or a sternotomy. This is done through a subxiphoid approach and Seldinger's technique. And if you have an ultrasound, that is very good, and you can see the path, how your needle is going, get into the pericardial space, remove some blood. Very, very difficult to remove because sometimes the blood has clotted, So you have to aspirate, use big syringe to aspirate. But the good thing with these patients, if you remove even just 3 mils of blood, of clotted blood, the heart has space to contract. Once you put in that the catheter, just leave it in situ and continue aspirating. Not many people have done this. Very, very few people have done this, and I think hopefully never happens to never get a patient like this, but that will be the treatment, because otherwise they are going to arrest, unless you can get them to theater, to the suite immediately, and they get the chest is open, cracked open, and this is sorted. Go to traumatic circulatory arrest. So the most common cause of arrest in trauma patient is hypovolemia. But as you've seen, we can have tamponade, tension pneumothorax, and other things that will kill these guys. With hypovolemia, the aim will be to restore circulatory volume as soon as we can, and manage them according to standard ACLS guidelines, that is cardiac CPR. But most of the time, if a patient arrests on you at trauma arrest, standard ACLS guidelines are not very effective. They are very, very temporizing. You imagine you are doing CPR on a patient who has no blood volume. You're not going to affect anything. You're doing a CPR on a patient who has the great vessels kinked from a tension pneumothorax. You're not going to, this patient has no, the right ventricle is not getting filled because the IVC is squeezed and the mediastinum is shifted. You're not going to get very far. So in trauma, always the 4Hs and 4Ts in the 4Hs, 4Ts really apply in trauma. You have to seek and correct. Otherwise, just CPR and pressing the chest up and down will not help. Actually, in a center where I worked before I came here, traumatic arrest, there was no CPR. And a patient had a traumatic arrest, we opened the chest. You crack open the chest and look in and do internal cardiac massage. You cannot do external CPR. But that is in very advanced centers. Here, now we have to do CPR. Do CPR as you are looking to correct the thing that caused, to correct the cause of that arrest. And there'll be hypovolemia, hypovolemic arrest, there will be a tamponade, tension pneumothorax. You have to look for those 4Hs and look for them aggressively and treat them. Otherwise, you're not going to go anywhere with your trauma, with CPR. These patients might have PA, might start with a PA arrest, then they just go into a ventricular fibrillation and a systole, and they die. If you do not correct the underlying cause, they are dead. CPR is not going to help much. But note, I'm not saying don't do CPR. I'm saying CPR most of the time is futile unless you correct the underlying cause. Right, flail chest, multiple rib fractures in 2 or more places with costochondral separation of a single rib from, or a costochondral separation of a single rib from the thorax. These patients need analgesia and they need ventilation assistance. So sometimes they might even need to be intubated to ventilate, to blow out the CO2, because the mechanics of ventilation are messed up with the flail chest. And they require lots of analgesia, narcotics, but remember, Achilles heel, you're giving them narcotics again, you might decrease their respiratory drive, but you can do blocks, interpleural blocks, extrapleural blocks, or epidural blocks. If you have someone to do it, get the anesthetist to help. If you have an anesthetist in your center, to do those blocks if you cannot do them. All right, pulmonary contusions with lung bruises, fractures of ribs. Children are far more compliant chest walls, remember that, and they may have no fractures to suggest a pulmonary contusion. And adults are likely to fracture, and they might present with subtle respiratory failure. So the CO2s are just climbing, and just consider a lung bruise. So blunt cardiac injury, this happens, of course, with a blunt chest wall force. And of course, you can only diagnose this with direct inspection of injured myocardium, which might be impossible. But there's sequelae to this. There is hypotension. Patients might have dysrhythmias, which will be PVCs, atriofibrillation, bundle branch blocks, and ST changes. That's why an ECG is a good adjunct to trauma patients, especially with chest wall trauma. Just do an ECG on them and try and pick up any dysrhythmias. They might have, if you do an echo later on, or if you have a facility for an echo in your centers, advanced centers, you can notice motion wall abnormalities of the heart. Always remember to treat the case, the cause, and the complications. So case here, they have a direct trauma to the wall, and by the time they have a cardiac blunt myocardial injury, that must be a lot of force. So look for other injuries, look for other associated injuries, treat them, treat the complications. And of course, in your secondary survey in circulation, you'll be looking, as talked about, blunt cardiac injury, traumatic aortic disruptions. Most of these die at scene, you won't get them. Traumatic diaphragmatic injury, I'll talk about it later. Very difficult to pick and can be missed. Most of the time, traumatic diaphragmatic injuries are picked up when patients come for review. Persistent pain, persistent maybe difficulty in breathing, and it's picked up. It's very difficult to pick up. Blunt esophageal injury is also difficult to pick up. Trauma, patients can present in shock. The key here is recognize the shock. Shock itself it's not a single entity that you look and recognize. So you have to clinical presentation and do some labs to recognize shock in these patients. So identify the etiology. In trauma, it's not only hypovolemic shock. That is the most common. There's cardiogenic shock, obstructive shock, neurogenic shock. A patient might have a high cervical spine injury and their blood pressures are low, and whatever you do, you're not raising the blood pressure. Always think of neurogenic shock. But the teaching there is that if a low blood pressure trauma patient, always assume it's hypovolemic shock and treat hypovolemic shock. Once you've corrected that, if they're persistent, then consider neurogenic shock. They can come in septic shock if they've come late with bowel perforation, and they might come 24 hours later and they're in septic shock. So consider that. So as I said before, manage the case, manage the cause, and manage the complications of this shock. So early antibiotics and fluids, replace the lost volume and all that. Consider tranexamic acid in exsanguinating patients. So in our primary survey of shock, we'll be looking at is the pulse rate and the blood pressure. Mainly look at skin perfusion, cold, clammy skin, cold extremities. They could be pale, decreased capillary refill, and altered mental status. Altered mental status can be an indicator of shock. Arrest the bleeding by external pressure, and if it's an internal bleeding, early recognition and expedite them to operating theater. They have to be opened up and the bleeding arrested. Get an IV access, not a cannula, blue cannula or a yellow cannula. If you can't get a wide bore IV access bilateral, take some bloods in for cross-matching and looking for lactate, which can be an indicator of shock if you're able to measure your lactate levels, hemoglobin, renal function. These patients could have had crash injuries and they could be going to renal failure. So bloods, baseline bloods, look at your potassium. If they've had crash injury, they could be hyperkalemic and all that. So there are bloods, standard trauma bloods that you will take. There's this question of crystalloids versus there's other fluids you give. I've never used them. I've forgotten what they're called. But if patients come, what are they called? Anyway, give crystalloids. You can give crystalloids and blood. If you have blood, it's best to give blood, especially if they've lost a lot of blood volume. It's good to give them blood. It's better. The better fluid to give them is blood. So you can give crystalloids if they're in class 1 blood loss, which I'm going to show you the classes of blood volume loss. You can give crystalloids, but if they are class 3, class 4, they've lost a lot of volume, best give them a blood transfusion. And of course, remember that areas you can consider autotransfusion, especially if they've had massive hemothoraces, the blood is in the cavity, you can consider autotransfusion. Remember tranexamic acid, and we are all doing this to prevent the deadly triad of hypothermia, acidosis, and coagulopathy. So as I said, class 1, hemorrhagic shock, they've lost about 15% of their blood volume. They have 15% blood loss. Class 2 is about 15 to 30%. Class 3 is 31 to 40% loss, and class 4 is greater than 30% loss. Hypotensive resuscitation, we can consider hypotensive resuscitation, especially in penetrating abdominal chest injuries. And hypotensive resuscitation is where you target a MAP of around 65. The blood pressure is kept low, about 90, 80 to 90, but always consider the patient's mental status and other vital lactate if you are able to. But it's a hypotensive resuscitation. You don't want to drive their blood pressures up, or they have ischemic heart disease, they get hypovolemia, and that precipitates an MI. So consider that. Obstructive shock, cardiac tamponade, tension pneumothorax, neurogenic shock, I've talked about it, cervical and upper thoracic spinal injuries. These patients will normally be hypotensive without any tachycardia or cutaneous vasoconstriction. So consider neurogenic shock. And as I said earlier on, septic, delayed presentation, penetrating chest or abdominal injuries. Abdominal trauma. So abdominal trauma, so they could have injured their solid organs, hollow visceral organs. They could have had retroperitoneal injuries or diaphragmatic injuries. These patients can come with a solid organ injury with minimal symptoms, non-specific findings on physical exam. Young patients will not have a very brisk physiological response to their injuries. They may have distracting injuries, consider head injuries, and also if they're intoxicated, that can be a distractor and they are not basically able to say where they are in pain. With abdominal injuries, serial physical examinations on awake, alert, and reliable patients is important in identifying intra-abdominal injuries. So these are some of the symptoms they can present with, or some of the etiologies. So splenic, left upper quadrant pain, commonly associated with that and other intra-abdominal injuries. They can have that CAS sign, which is a referred left shoulder pain, which is a classic finding in splenic rupture. Lower rib fractures should heighten clinical suspicion for splenic injuries. And the liver is commonly injured in blunt and penetrating injuries. There are some physical signs that you can pick up in a patient with abdominal examination. And I think in abdominal examination is always exposing these patients, examining them, log rolling them, and looking at the flanks and at the back so that you do not miss any sign or any sign. Remember hollow visceral organ injuries, and these ones will present with blood loss and peritoneal contamination and septicemia later. So avoid by picking them early and managing them as appropriate. Retroperitoneal injuries are very difficult to pick, and these are some of the organs that can be injured. There's a third Parker mnemonic to remember that. So suprarenal or adrenal injuries, aortic and IVC, pancreatic injuries except the tail. The pancreas is a peritoneal organ in part of it. The ureters can be injured, the ascending and descending colon, kidneys, esophagus, and the rectum. Some part of the rectum is retroperitoneal. So consider these injuries. So diagnosis of retroperitoneal injuries is challenging. The signs and symptoms can be subtle or absent at initial presentation. And basically, they can just be from an intramural hematoma to an extensive crash or a laceration can cause these injuries. These are some of the mechanisms in hollow organ injuries. So duodenal, high-speed, vertical or horizontal decelerating trauma, and pancreatic injury, rapid decelerating injury, and unrestrained drivers with the steering column, or cyclists who fall against a handlebar. Some of the findings, clinical findings. just before I talk about this slide, there is this misconception, or I'm not sure if it's a wrong use of FAST, the FAST exam. The FAST exam is a point of care ultrasound exam. By point of care means that it's a bedside exam. So if you have the skills to do FAST, you do FAST in the emergency department. If the patient, by luck or by design, that means he's stable and has been taken to the radiology suite or to the radiology rooms, that is not the place to do a FAST. Do a CT scan of the abdomen. I have seen cases where clinicians have requested for a CT head, CT C-spine, CT chest, abdominal FAST, and X-ray of the pelvis. So you imagine the radiographer now is doing the CT and then on the abdomen, and they're trying to poke the abdomen, and it's operator dependent. In my mind, the FAST exam is very, very clear. A FAST exam will tell you, is there free fluid in the abdomen? And actually, even lack of free fluid in the abdomen does not mean that there's no abdominal injury. That has to be correlated with a clinical exam and vitals and all that. So a patient comes in, I do a FAST, and the patient is unstable. That patient does not go to the radiology suite. That patient goes to the operating theater. A patient very stable comes in, very mild abdominal injury, and you are debating, should I scan this patient? Should I do an abdominal CT scan? The mechanism, so you've gone through the mechanism, clinical signs, and everything, and very mild tenderness, which nothing much to write home about. Then you'll do an abdominal FAST exam and see it's clear there's no free fluid, and the patient examines well. The patient is very stable. Then I will maybe not scan him, or if it deteriorates later, we will scan him. But the FAST does not tell you much. The FAST only guides you as to the next steps. So we should take that thing out of requesting FAST scans to sonographers to do FAST scans. Actually, sonographers should not do FAST. FAST scans should be done by clinicians on the bedside. I'm going to ask Dr. Wachira to comment on that later as we go on. But in abdominal injuries, surgical judgment is required to determine the timing and need for laparotomy. These are some of the indications when they need for laparotomy. So blunt abdominal trauma with hypotension, with a positive FAST, or clinical evidence intraperitoneal bleed without another source, so they need to be opened up. Hypotension, abdominal wound, open them up. So a patient has a knife sticking in the abdomen, straight in the abdomen, lodged there, and they're hypotensive. We will not do a scan on him, just open the guy up. Gunshot wounds, which traverse that. But maybe the surgeons can ask for CT scans to guide their management or to guide whatever they're going to open. So those are some of the indications for LAP. I'm just going to play a video on FAST, a brief video.
There are 4 standard views in the FAST exam: the pericardial view, the right upper quadrant view, including the interfaces of the diaphragm and the diaphragm spleen interface. Start by viewing the subxiphoid or the parasternal view to ensure the gain is set appropriately. Fluid within the heart should appear black. The presence of fluid outside the heart within the pericardial sac is abnormal and is consistent with the right upper quadrant view is a sagittal view in the mid-axillary line at approximately the 10th or 11th rib space. Visualize the diaphragm, liver, and kidney, as well as the entire hepatorenal fossa or Morrison's pouch, looking for fluid. In a traumatically injured patient, the presence of fluid between the diaphragm and liver, or liver and kidney, is blood until proven otherwise. The left upper quadrant view is a sagittal view in the mid-axillary line at approximately the 8th or 9th rib space. The diaphragm, spleen, and kidney interfaces are visualized, and as in the upper right quadrant, any fluid visualized is blood until proven otherwise. The suprapubic view is a transverse view that is best to obtain prior to placement of a Foley catheter. In this view, the area behind the bladder is examined for the presence of fluid, which, if present, is abnormal and consistent with hemorrhage in the trauma patient.
So something else I'd like to say about POCUS in trauma fast. You can do an extended fast, especially, for example, a patient has a chest injury and they are very unstable. You don't have a mobile X-ray machine. Patient is stable. You can do an extended fast and look for pneumothorax, pneumothoraxes, and even hemothoraxes. And actually, in the supine patient, an ultrasound is more sensitive than an X-ray in picking up pneumothoraces in experienced hands. As I mentioned before, diaphragmatic injuries are very insidious. They're occasionally obvious. So if a patient comes in and they have bowel sounds or scaltated in the thoracic cavity, you can pick up a diaphragmatic injury, but very, very difficult to pick up these injuries. You have to have a high index of suspicion. And in a chest radiograph, you'll see an nasogastric tube coil in the thorax, or there'll be blurring of the diaphragm or an effusion on that side. So high index of suspicion, especially in dangerous blunt intra-abdominal injury, even penetrating, could have been stabbed up into the diaphragm. Pelvic fractures, big killers in trauma, very big killers in trauma. So these are mechanisms of pelvic fractures. There's anterior-posterior compression, there's lateral compression, and there's shear, vertical shear, which vertical shear accounts for frequency of 5 to 15%. Lateral compression actually at the most that we see about 70%, and anterior-posterior compression about 20%. In a patient who has trauma to the abdomen, consider pelvic injuries as well. And pelvic injuries are easy to immobilize if you do not have pelvic binder. You could use just a simple bed sheet and tie them. So during the primary survey, as you are going down, when you have exposed, you're going down, you can do a pelvic spring test. Gently hold the anterior superior iliac spines and push gently. And if the patient if the patient is conscious and they are in pain, hold them and then bind them before you leave. Remember, seek and treat. You find, don't move before you treat. Just bind the pelvis and then manage it. In more detail, pelvic injuries, initial pelvic injuries in trauma centers, initial management of pelvic injuries, especially the shear type where the obturator vessels and all that are injured, that is not an orthopedic problem initially. It's a radiology problem where you'll do radioembolization of the vessels and all that in advanced centers. I'm going to play a video of pelvic binding just to see how it's done.
Examination of the pelvis. Log roll maneuver. Go on in. 1, 2, 3. Placement of the binder. And then down. 1, 2, 3. And securing the binder.
So remember, if you don't have a pelvic binder at your center, you can use a bed sheet. Very easy to do. Put the bed sheet under and just follow those steps. Very easy to apply. Head injury. The primary goal of management is to prevent secondary brain injury. So patient comes in with a suspect head injury. Always remember a head injury, any patient with a head injury should be assumed to have a thoracic, cervical spine injury, until, especially if it's a severe head injury, you have to image the C-spine as well. So a patient with head injury, by default, have a cervical spine injury, and you have to clear that cervical spine. Most often, you're going to clear that cervical spine radiologically and not clinically. So they'll need radiological clearance of the cervical spine as well. So head injury, maintain adequate oxygenation, maintain blood pressure, and of course, with a head injury as well, there are airway issues. If the GCS is dropping, you have to protect the airway as well. Remember your AC, that's airway, C-spine, breathing, circulation, D and D. Remember that, follow that, and transfer to a facility where imaging, that is a CT brain, I forgot to put there, plus a CT C-spine can be performed and managed as appropriate. Glasgow Coma Scale, of course, when you are calling to transfer and even your documentation. So there's a revised scale of Glasgow Coma Scale. I always stick to the original one. So let's try and avoid these things where you are getting an handover and you are being told the GCS is 2 or the GCS is 3.5. So let's just acquaint ourselves with the Glasgow Coma Scale. So just a small classification of traumatic brain injury with severity, mild, moderate, severe, and some morphology with skull fractures, the vault, the basilar, and some intracranial lesions which are focal and diffuse lesions. So diffuse brain injury, we can get concussions or diffuse axonal injuries, and focal brain injuries, subdural hematomas, epidural hematomas, subarachnoid hemorrhages, and that's a subdural there. Epidural hemorrhage. I think there's some falcine herniation there as well, and subarachnoid hemorrhage. Head injury and imaging, especially in children who sustain very mild head injury and are brought to our departments, and departments where we have CT scan available at just ordering a form and you get a CT scan. It's very difficult, especially in children, to determine whether or not these kids need a CT scan. In adults, it's easier to make that call. But there's many rules. There are Canadian, New Orleans, and Nexus 2. This, I prefer using the Nexus 2 rules for quick determination to determine I'm going to scan that kid or not. Of course, there are some issues also with scanning the children, especially if your CT scanner does not have a pediatric protocol in it, so you are going to be giving them a big whack of radiation. So I just, if the patient has any of this, and the mnemonic is Binbash, if the kid has any of that, then I'll scan them. If they have a behavioral change, the parents tells you the patient is not behaving as they should, vomiting more than 3 times, age, forget that, that's for adults Nexus. And if they have any neurological deficits, if they have any bleeding diathesis, and that means they're coagulopathic for any reason, either acquired or inherited. If they have any altered conscious, if they've had a altered conscious state, they lost consciousness for some time. If they have an obvious skull fracture, base of skull fracture or an obvious skull fracture, or they have a big hematoma on the scalp, then they score a CT scan. If they don't have any of that, then there is and this Nexus 2 rule has been verified in children and in adults. If they don't have any of that, then there is room for observing them and just serial observation, serial neurology, and scanning them at the opportune time if they develop any of that. And of course, putting the parents in the picture as well, and alleviating the anxiety. Just a quick note on musculoskeletal injuries, traumatic amputations, consider reimplantation, especially if there are facilities or if you can get them to a place that reimplantation can be done. Let's try and do that for the patients. Consider vascular injuries and the musculoskeletal injuries. So you just don't look at an X-ray and look at the bones themselves. Consider the tissues as well. Crash syndrome, which can be devastating with rhabdo, metabolic acidosis, hyperkalemia, hypocalcemia, and eventually DIC. And much more.